Good morning, everybody. Thank you so much for coming to session 228, Lessons of an Empowered Patient and Her Caregiver. Just as a reminder, if you go to the HIMSS app, you can download our handout, and we'd really appreciate it if at the end of the session you'd be able to go in and fill in the survey, as we'd really appreciate your feedback. So my name is Christina Sheridan. I'm a department head and a healthcare researcher at the MITRE Corporation. MITRE is a not-for-profit organization who works in the public interest. And this is my daughter, Kate Sheridan. She's a junior at George Mason University, studying health administration and policy, and she's currently abroad studying public health at Oxford. So before we begin, neither Kate nor I have any real or apparent conflicts of interest. We're going to be talking today about patient engagement, and specifically how developing patient-facing tools and empowering patients really help with health outcomes. We're going to be talking about best IT practices and how you can develop patient-facing tools to help enable patients. We're going to be talking about real-world experience and how being engaged and an empowered patient really helps outcomes and what a difference it can make both to the patients and to the clinicians. And we're also going to be demonstrating examples of ways that you can engage and empower patients in your own organizations and as individual patients. So what we're going to be talking about today really hits on all 5 of the value areas within the HIMSS framework. And I'm not going to speak to every one of these right now because we're actually going to hit it as we go through our presentation. So before I start talking about the research that we've been doing around patient engagement and patient empowerment, I'm really proud to introduce my daughter, Kate Sheridan, who's going to be sharing her patient story and really putting context around why this is so important.
Hi, I'm Kate. As my mom mentioned, I'm a student. I'm studying health administration and policy. I'm also a chronic patient who survived an 8-year journey battling multiple chronic conditions. Over a decade ago, when I was in 5th grade, I suddenly developed flu symptoms and a classic bullseye rash on my face. I was quickly diagnosed with Lyme disease and given 3 weeks of oral antibiotics. Despite what we thought would be a simple diagnosis and treatment, my health continued to decline. And over the next 3 years, I was referred to over 30 doctors, given 15 different diagnoses, and was hospitalized 5 times. During that period, the disease progressed through my body, and my cognitive abilities and memory began to fade. I went from being a straight-A student in an advanced academic program to a special needs student, incapable of reading a single page of a book. It crept through my limbs, swelling my joints and stripping me of my energy. I went from being a competitive athlete to wheelchair-bound. A hot, burning sensation began to flicker through my feet and up my legs and crackled across my back and my neck. My pain became excruciating, running between a 7 and a 9 out of 10 all of the time for 18 months straight. These symptoms stripped me of my ability to read and run and write, but I loved art and was able to continue creating pieces throughout my illness. Art became a coping skill that helped me express what I was experiencing, and many of the slides that I'll share today are images that I created during that time. So over those first 3 years, we built a team of 6 specialists, top in their field, who were dedicated to improving my health. But despite their help, I continued to deteriorate. My family and I became overwhelmed by everything. Appointments became a blur. I had received so many different diagnoses and treatments that attempting to accurately communicate my medical history became impossible. When my medical team referred us to yet another consultation, my parents spent weeks collecting and organizing my information in an effort to tell my story more effectively. This was the turning point in my care. By changing the way we communicated, we built better relationships with my doctors and improved the way we managed my care at home. Those 3 things, communication, doctor-patient relationships, and self-management, were key elements of my recovery and are the main topics I'm going to focus on today. First, I want to discuss communication. As we attempted to navigate the medical system as an adult is challenging. As a child, it's profoundly indecipherable. My life had very suddenly fallen out of my control, and I was inundated with terms I didn't understand, invasive examinations, and isolation from my peers. It often felt as if my life was moving very rapidly and that I wasn't a part of it, and that was escalated in the clinical setting. I witnessed many conversations that directly impacted my care happening around me, and could go through entire appointments where screen time replaced personal eye contact and recognition. I walked into the appointment as a person, and I sat down as a diagnosis. Because of that, learning how to communicate with my doctors was a vital component in improving my care. It could be difficult deciding what information to share and when, what constituted as a symptom, and which symptoms were worth mentioning. I was dealing with lots of physical and mental ailments and side effects, and they naturally prioritized themselves in my head, from most harmful to least. Sometimes I didn't even think about a symptom as a symptom, because I'd been dealing with it for so long, it kind of just became part of my new baseline. During one appointment with my cardiologist, who was treating me for a condition called postural orthostatic tachycardia syndrome, he mentioned I was surprised I didn't have any numbness or tingling in my feet. I was laying on the examination table, and I responded that my feet had been numb for months. I just didn't think it was important enough to share. I mean, I was in constant pain. I felt like passing out every time I stood up. I didn't think about my numb feet. That night, my parents made a list of all of my symptoms, head to toe. There were 26 of them. We were shocked. I had never mentioned more than 10 in a single appointment. So they set up a rudimentary tracking system in Excel, and every week or two and before my appointments, I'd fill in the severity of my symptoms. We shared that data with my doctor, pointing out any major changes to my condition since my last visit. That one appointment with my cardiologist made us realize why tracking my health data at home was so important. By collecting that information ahead of time, right, we were able to make sure we disclosed everything fully in appointments, and it allowed us to visualize my symptoms over time. When progress was slow and it felt like my treatments were doing nothing, the data helped encourage me that things were still getting better. And when things began to decline, it was still beneficial to see. Sometimes between my myriad of symptoms, it could be hard for me to identify and communicate exactly what was getting worse. Small changes in my condition could mean infection or a bad reaction to meds, and catching those changes early prevented a trip to the ER. The data helped legitimize what I was feeling and gave me confidence in evaluating and communicating my own state of health. That's because once organized, the data became a language that both my doctors and I could understand. In the abstract, the masses of information we'd collected on my case weren't particularly useful. The countless blood test results, symptom scores, medication lists were overwhelming and useless, stuffed into file cabinets and rolling suitcases. But once we found out an easy way to organize and analyze it, the data moved from a burden to a tool. In the abstract, the jumbled numbers seemed jumbled. But placed into organizational frameworks, they told my story. My pain increased with XYZ medication. We could expect my fatigue to flare when I became vitamin deficient. Once unlocked, it was a whole new method of communication that my doctors could rely on and that we could utilize to better predict and understand my illness. Social communication was also a huge barrier to regaining some normalcy in my daily life. There's a lot of preparation required when you first get sick, and coming to terms with isolation is a major one. It can be hard to understand the burdens and intensity of chronic illness from the outside. I was 11 when I first got sick, and I had lots of friends at school, on the soccer team, in the neighborhood. But by the time I was 13, I was spending less and less time in school. I couldn't play soccer, and I didn't have the energy to run around the neighborhood. The physical limitations of my illness were hard to deal with, but the loneliness that accompanied them was equally debilitating. Because of this, as I entered high school, finding ways to maintain friendships and cope with all of that was vital to maintaining an identity and maintaining friendships. I reached out to Lyme disease networks online, kept in contact with friends through social media, and attempted to attend at least 1 or 2 classes at school. I also worked really hard to appear healthy and well-rounded. I listened to news podcasts and watched whatever was popular on TV so that I always had something to talk about that wasn't related to my illness. And in addition to communicating with friends, it was also difficult communicating with my teachers in the school system. Lyme disease, autoimmune diseases, and POTS aren't super well understood, and treatment plans can vary drastically from patient to patient. It was our responsibility to serve as translators between my doctors and my teachers and come up with appropriate accommodations for my symptoms. This is a current gap in healthcare that can make life outside the doctor's office much more stressful. We were attempting to come up with accommodations for an illness we didn't understand or have a handle on. We figured out how to utilize my health data, and based on that, we knew I needed extra support, but we simply lacked the health literacy required to adequately explain that to administrators. Luckily, one of my doctors wrote a letter in layman's terms that was easy for both us and the administration to understand. It explained my symptoms and appropriate accommodations for each of them, ranging from free access to the clinic so I could take naps when I needed to an elevator key for when I couldn't make it up the stairs. Having suggested accommodations based on my diagnoses and help explaining to the school why they were necessary was hugely beneficial and would be a great asset to patients if it was more accessible. But there were also times when it was important for us to create barriers between social and clinical communication. At home, we had to remind ourselves to maintain that split between caregiver roles and family roles. My parents did many medical things for me. They gave me pills, IV treatments, injections. They drove me to doctor's appointments and tests. It was really easy to fall into the habit of only talking about medical challenges and symptoms and doctor's appointments. So we made time consciously to be a normal family. Sometimes this was as simple as sitting around the dinner table and talking about our days, but we also still went to Florida every year, lugging along my medical equipment and wrapping my IV lines in cling film. Keeping up with normal tasks and traditions allowed us to continue making positive memories despite my illness. Overall, we found a balance. In the clinical settings, the focus was recovery, but at home, the focus was living. So as we gradually became better communicators, we still ran into difficulties with my doctor-patient relationships. When I tried to explain why I couldn't attend school some mornings, I was told I was just being a difficult teenager and that my symptoms were all in my head. In these cases, we ended up relying on my data defensively to prove something was wrong and provide tangible evidence to the changes in my body. The 6 doctors who made up my final care team listened to what I had to say and asked questions for clarification. They heard me, and they took my feedback into account. There was an equilibrium between time spent with my electronic health record and time spent face-to-face discussing strategy. Because of that, they knew me as a whole person and not just as a set of data on their computer. Those 6 doctors were also the people who weren't willing to give up on my case. I didn't fit into conventional treatment molds, and it was really hard to establish a successful care plan. We originally navigated the medical system by bouncing between silos that adhered to my individual diagnoses. This didn't work well with my case. As someone with multiple chronic conditions, many of my diagnoses were interconnected with overlapping symptoms. It could be hard to establish causation, keep track of contraindications, not to mention making sure all the members of my care team were aware and approved of any changes in my care. Some things, like patient portals, made it easier for us to organize that information, but none of them were interoperable, so it was still hard to keep track of who knew what. We relied heavily on our homemade Excel symptom tracker, where we could take all the information we shared with my doctors and compile it into one easily shareable document. It took flexibility, humility, and teamwork, but my doctors ensured my case didn't fall through the cracks. They worked well not only with my other providers, but welcomed us in as part of the team. When we arrived with our stacks of data and symptom scores and medication lists, they embraced the information and asked for more. We felt like equal partners in my care. There were also things I did as a patient to reach out and create better relationships with my providers. Emergency situations, for example, could exacerbate many of the doctor-patient challenges, where from necessity, actions would become mechanical and often painful. I had a pair of shoes that I would wear anytime we had to call 911 or visit the ER. My emergency shoes, covered in bright splashes of color. I wore them because I knew that my EMTs and nurses would see them and probably comment. That comment would allow me to make a joke about my crazy sneaker collection, and suddenly I wasn't just a patient. I was the kid who loved sneakers, just like their kid or their niece or their sibling. As crazy as it sounds, that tiny personal connection completely changed the level of care that I received, from big things like spending more time putting in an IV to small things like extra goldfish. It gave me something to talk about that was under my control, and that same thing helped my EMTs and nurses and doctors see me as an individual and connect to me. A quirky pair of sneakers completely changed our relationship for the better. This allows me to segue into my last topic, self-management. Although finding ways to better our experience with the doctors was important, most of the time spent handling my illness took place at home, so self-management was a skill essential to maintaining autonomy and progress. Health data was a critical part of that management, but there were also many issues in which relying on data alone wasn't enough. The fundamentals of my treatment plan could be established in the appointment, but its functionality was determined at home. Medications, for example, were easy to analyze with data and prescribe at appointments, but at home, they could impact my most basic functions. A painkiller that made sense to prescribe on paper might also make me lose my ability to focus, so I'd end up skipping it to pass tests and turn in homework on time. In addition to medications, there was the equipment that came with it. IV poles, pumps, bags, syringes. All of these were restrictive, and all of these we handled at home. I can tell you, trying to make an intravenous catheter look fashionable for your first ever day of 10th grade is no easy task. Maintaining normalcy usually meant getting creative, taping down my Metaport tubing, hiding IV pumps in my backpack, and wearing oversized sweaters to hide my heart monitors. And these small changes made huge improvements to my functionality, and they didn't stop at purely medical necessities. I integrated my support mechanisms, turning things that were part of my identity into coping skills. When I could no longer play sports, I went from athlete to coach, calling out from the sidelines when I was too tired to stand. I switched artistic mediums from pencils, which I could no longer hold due to arthritis, to mixed media, which was easier to grasp and pass the time during IV infusions. When I could no longer sit at the piano for long periods of time, I picked up the ukulele, which I could play from bed. These changes kept me grounded in who I was. I was still an athlete, just not on the field. I was still an artist, harnessing new media to express myself. And I was still a musician, expanding my skill through songwriting on the uke. Harnessing alternatives to my passions to boost my morale and maintain my identity was just as important as harnessing health IT to boost our effectiveness as patient and caregiver. Overall, these things helped us find a balance to treating my illness and managing my life. They were changes that took into account not just the physical burdens of being sick, but also the psychological. When we thought about a new treatment plan, we discussed both the medical details and how it would impact my day, and ways to minimize that impact. Over time, we built notes into our ever-expanding Excel tracker, learning to include both physical symptoms and quality of life. The last and little discussed step in finding balance in my treatment plan was adding a new member to my care team, a therapist. My therapist acted as a soundboard to help us establish our new normal. She helped keep me grounded in who I was, rather than allowing me to adopt my disease as an identity. Adding psychological support was the missing piece in a holistic approach to my recovery, and the effects were notable. For some reason, the psychological and physical parts of being sick had been viewed as separate entities, when in reality, they were closely related. By having psychological support in place, I could do things like deploy better coping skills to deal with my pain, reducing my reliance on painkillers. By decreasing unnecessary meds, I could focus better and go to school more often, culminating in better moods and higher productivity. And, most importantly, my therapist helped my parents stay sane during what was a very sassy goth phase. By the time I turned 17, I had been sick for over a third of my lifetime. We had no idea if I would be able to go to college, live independently, or ever be pain-free. But the three things I discussed today, communication, doctor-patient relationships, and self-management, were key to allowing me to recover and share my story with you today. Utilizing health data was a critical part of that journey, but it's important to note that it coexisted within a comprehensive plan that factored in both clinical approaches and quality of life. In summary, yes, I am a chronic patient. I have diagnoses, and I have vital signs, and I have medications, but I'm also Kate. I'm an artist, I'm an athlete, I'm a student, and I'm a daughter. And the reason I can stand before you on stage as a healthy person today is because my doctors, parents, and teachers never lost sight of that. Thank you.
Thank you, Kate. I love you. Okay. So Kate mentioned a time 3 years into her illness when we reached a turning point in her care. I'm an engineer by trade, so I think data. And as her parent, mom, caregiver, I was responsible to try and communicate between all these different doctors who she was seeing, making sure that they had the right information in order to help her and to be able to advocate on her behalf. So the first year, because I think data, I was able to walk into those appointments and really clearly and accurately and effectively communicate what had happened to her over that period so that the providers could then use that information to help her. By the second year, things were getting a lot more complicated, and it was getting a lot harder to do that. So I had to rely on Post-it notes and pieces of paper. And by the third year, I was awash. There was so much going on. It was so hard to actually keep everything in my head and everything on paper and everything organized that we couldn't advocate for her. And 3 years in, she was getting sicker and sicker and sicker, despite the fact that we had found these 6 amazing specialists who were dedicated to her care and working with us to try and turn her around. So that experience, actually, my background is not in healthcare. My background is in astronautics and space engineering. And the experience that we went through is actually what made me leave that space industry and come into the healthcare. What we actually did, because we had the background that we did, we took a step back. And when she was referred up to New York 3 years into her illness, we went back to all of those 30 providers and we got all of her data. Every one of those 30 people had a piece of her story. And nobody had the whole thing. And we were the only ones, we realized, who had access and connection to each of those different points and could therefore bring it all together into one place. So the first thing that we did is we went out and we gathered all of our notes and we got it, and it was 1.5 feet tall. So we had it in one place, but it wasn't very usable to help with communication. So Kate mentioned all those spreadsheets that we sort of developed, and these are the spreadsheets. We took that data and we combined them down into Excel spreadsheets, and there was 2 sets of data in those spreadsheets. The first set was the clinical data that we got from the providers. We took our lab work from everybody over time and we hand-typed it into Excel spreadsheets. We took our medications across everybody and we developed this historical timeline. But equally as important, we captured Kate's data, patient-generated data. She mentioned that aha moment for us when we realized there was an awful lot more symptoms that she had that we had any idea about. She had 26 by the time we actually finally went through from head to toe and identified everything that was going on. So we captured those symptoms. And then on a weekly basis, we didn't want to do it too much because we were thinking about illness enough as it was, but on a weekly basis, we went in there and she told me how severe those symptoms were. And in our spreadsheet, we tracked that. Also, we went in and looked at those medications, and from our memory and our recollection, we wrote down how she responded to those medications, not through her clinical data, but how it impacted her everyday function. Did it stop her from going to school? Did it stop her from thinking? Did it help her? Did it enable her to get out of bed? And we captured that information for us, for reference, in those spreadsheets. So better than the pile, still not great for communicating. So we took one more step. We took that data and we took one 11 by 17 sheet of paper. And across the center, that dark line across the middle, every time she sat down and filled in the symptoms for severity levels, we totaled the total severity of all of her symptoms. And that, to us, represented the burden of all of her illnesses on her as a child. It gave us one number that we could look at simply and easily, so that when our gut said, something's not right, I didn't have to start scrambling through my head to try and figure out what it is. I had her data that I could look at, and I could see if things were getting worse, and if they were, I could look to see what those symptoms were, and that empowered me to take better action. Across the bottom of that 11 by 17 spreadsheet, we mapped out all the different medication treatment trials that had been tried over that 2.5-year window. And so that you could start to see when they tried this medication, what did it do overall to her physically? And then across the top, we took the abnormal lab results that had been causing the providers to stop her treatment because she would go neutropenic. And we took those abnormal lab results and we mapped those out across the top. So using that one sheet of paper, in addition to the data in the suitcase that we dragged on wheels behind us, we were able to walk into that appointment, sit down quickly, articulately, and accurately and completely tell her story. And using that data in combination with their data, the providers were finally able to unravel her story. They verified the root cause infection was still there, Lyme was still active. They identified a comorbid condition that hadn't been identified, another tick-borne illness. They identified autoimmune issues that had developed over time as a response to that. And they also developed other areas. They had the complete picture laid out. And once they understood it and were able to get that insight, they came up with a treatment plan that got her well. And over the next 18 months, she was back in school part-time. She was coaching her little sister in basketball. And she was on her road to recovery. So we were really lucky. Okay, I mentioned before that my background is not healthcare. It's astronautics and space engineering. 3 years in, when we did this, I was working in a launch control center running satellite missions during the day. And at night, I was taking care of Kate's data, organization, and pulling this together. And I can tell you right now that that day job was far easier than the night job that we had to do. And the reason it was easier is because when I walked into the launch control center and I ran a mission, I had screens in front of me, IT screens that were developed for me with my involvement, things that I could use easily and quickly to identify a problem with the satellite and figure out how to respond to it. But at home, when I went home, we had nothing. And we had to develop the IT ourselves, and thank God we had the background to do it. So it was that inequality and difficulty that really did inspire me and say, I love space and I love launching satellites, but I want to fix this more. And that's why I transitioned to MITRE, which is a not-for-profit organization, and they have an independent research program. And I put in a hypothesis and said, if we enable and empower patients and caregivers to bring their expertise and user expertise and help them self-manage and help them communicate well, we will have better outcomes, and there is a good chance that we'll reduce costs. So I love this quote. People are experts in everyday living. Physicians are experts in clinical care, and technologies bring them together. Patricia Brennan had this quote. I want to focus on that first sentence for a second. People are experts in everyday living. Patients and caregivers are experts in everyday living with chronic disease. They know exactly what has to happen in the 99% of time that they're outside the clinical setting. They manage it, they do it, day in, day out, minute in, minute out. But we don't recognize that expertise or that value, and we don't enable them to really tell their story to explain what's going on and impacting their health. So a lot of our research is focused around that particular aspect. We are looking at how do you embrace and empower and bring to bear that expertise of the patient and the caregiver. So at MITRE, we have this program, but we need to choose research that is at a national level. You've just heard a very personal story, okay? This is very close to our hearts, as you can tell. But this isn't just our story. In the US, there's 117 million chronic patients in this country today. And of those 117 million patients, between a third and a half of them have multiple comorbid conditions. So just think about that for 1 second. Look to the people either side of you. Just take for 1 second. Look left to right. So 1 in 3 of you has a chronic condition. 1 in 6 of you is dealing with multiple chronic conditions, just like Katie was. And there's another 54 million caregivers, like my husband and I, who are helping to take care of those chronic caregivers. This is a national issue. And if the numbers aren't enough, the cost, $2.9 trillion in healthcare dollars spent every single year, 86% of those dollars are spent on behalf of those chronic patients. So this is why this is such an important issue for us to embrace. We have 117 million patients out there today who are dying to be able to self-manage more effectively, who want help to be able to do what we were lucky enough to be able to help Kate's doctors do for us. Okay, so all we have to do is make it happen. So there's actually a lot of evidence right now that engaging patients really has substantial benefit. So for example, there is data that shows that patient empowerment, patient-centered care, and bidirectional patient-provider communication improves patient outcomes, quality, and efficiency of care. When patients believe that they are at the center of their care, patient satisfaction increases, length of stay in hospitals decrease, and fewer medication errors occur in general, all contributing to improved quality of care. There's repeated evidence that when patients feel empowered, costs decrease because there's a reduction in utilization in the primary care setting. And when patients perceive that their care is more patient-centered, the rate of diagnostic tests and referrals decreases by as much as half, which improves the efficiency and the cost of care. So despite this evidence, right, this demonstrates that the value of patients and caregivers as a whole is still not recognized widely or leveraged. So why? So we've been thinking about this a lot because it's kind of common sense, right? But culturally, we don't recognize or view or respect patients and caregivers as experts currently. We recognize and respect providers, absolutely. We value the data, the clinical data that comes out, and even now we've really moved on a little bit beyond that to include wearables and monitor data from patients. But what we don't recognize is that patient who sits in the chair and their caregiver are also experts. And they have what we call active patient-generated data, subjective data. How bad are their symptoms? How is it impacting them? Why can't they take their medications? That we don't value and we don't leverage, and therefore we haven't built tools to enable that data to come into play. And that's the gap that our research has been focusing on. So Mite is a systems engineering company, and I am a system engineer at heart. So as we started our research, we started people, process, technology approach. So looking at the people aspects, so why is it that patients and caregivers can't do this when it really has a lot of value? So in this room, if you're healthy today and you don't have a complex chronic condition, there's two things that you do overall, apart from fixing your car and doing jobs and stuff. But you go to work and you volunteer, right? And you have fun with family and friends. So you get through life doing mostly these two things. If you're a complex chronic patient, you still have those two things to do, but you've got all this other stuff to do at the same time. So we have some really wonderful thoughts, ideas, and words in our healthcare language today. Engaged patients, proactive patients. We want people to be shared decision makers, right? Partners in our care, empowered patients. It's fantastic vision. But the reality is, for patients and caregivers, they have all of this to deal with, and adding that on top without helping them and giving them tools is completely unrealistic. So moving on from the patient need and understanding why they can't help, we then moved on and we said, okay, if we want to find a way to help patients, we need to understand the patient workflow. This is a best practice in IT all over. You build a tool to support and optimize a process flow, and we do it all the time for those people that we value. Right? We design electronic health record systems to support the process flow of providers. We do it all over. Satellite Control Center, right? They did it to support our workflow. But we don't often build patient-facing tools to actually embrace and support the workflow and the things that they have to execute on a day-to-day basis or when they're meeting with their providers. So we've developed workflows to really look at the decisions and things and actions that patients do on a daily basis. And we identified touch points in those workflows that we said, boy, we could give the patient a tool here that would be really helpful. This is hard. What can we do to alleviate that? And we developed a set of requirements for a patient-facing tool that would support them. But we do research, so we also wanted to go out and we did an environmental scan, and we looked at all the other patient-facing tools that are out there today, and we eliminated the things that were already being done within the requirements. And we were left with three key gaps. The first one is the ability to track what I mentioned before, this active patient-generated data, or the patient voice. The second one is actually designing the application to fit into their day. so that they want to pick it up first thing in the morning and keep it with them all day because it helps them, and not because they've got 6 icons on their app that they have to remember to bring up at the right times in order to use it, because that adds burden. And then the third gap was actually a way to use the data so they could actually improve their day and do things more effectively or communicate better, because a lot of these things collect their own little pieces of information, but you can't compare them. So you can't do cause and effect analysis. You can't look at something and verify something. It's disparate pieces of data that can't be used. And those are the 3 gaps that we focused on. So before moving into the technology piece, I want to mention, so we don't commercialize our stuff, right? But in order to research and find the right ways to help patients, we need to develop technology, A, to figure out best practice on how to do it, and more importantly, to get it out into clinical studies and use it to build the evidence that shows how these sorts of tools do actually help patients and providers. So we had to choose a platform, and we chose an iPad platform to roll out in terms of the technology to build the prototype. But I want to reference everything I'm going to show you today can be done anywhere. It can be done on a piece of paper. It can be done through a phone call. It can be done in the doctor's office when you're logging in. It doesn't have to be an app. So this isn't about the technology. This is about thinking and acknowledging and finding those things that will help patients on a day-to-day basis. So within the technology, 3 areas: track, manage, and share. So we're tracking 2 sets of data. And the first set of data is symptoms, right? We had our experience with it, but we also found as we researched with both providers and patients that this is a huge gap. There's 2 issues with tracking symptoms today. Okay, the first one, Katie referenced. Patients often can't identify a full set of symptoms. They don't, sometimes they've had a symptom so long, it's become their normal baseline. So they don't communicate it as a symptom because they're not trained, and nobody sat them down and said, hey, it would be really helpful if you tell us this, right? So they're doing their best, and they're telling you the things that they think are important. But it's very hard to identify those things. So within the toolkit, we have a very simple list of symptoms that they go through when they first open up the toolkit, and they can select their full set of symptoms. A couple of things I want to reference on this. The first one is, it's a whole set. It's not by diagnosis. If you look at a lot of apps that are out there right now, they track symptoms to one specific diagnosis. 1/3 to 1/2 of chronic patients have multiple comorbid conditions. So this tool we did across the board. This is from a patient's perspective, not from a diagnostic perspective. The second thing I want to mention is, and this was a huge gap when we did the environmental scan, we map those symptoms to SNOMED CT codes. If you look at patient apps out there today, it gathers data, but it gathers it in a way that is not interoperable, that can't be shared, and it's not related to clinical data. There are data standards used in electronic health record systems by providers for symptoms. So we include the data standards within the tool so that our vision, and I truly believe it will happen, that we will be able to integrate this data into EHR systems. And when we are, if you're building the standards up front, you'll be able to connect very easily. There's another advantage of doing that. I mentioned that this is an example. We have to be very conscious to make sure that these capabilities are for everybody, not just people who have access to IT, and not just people who have got the ability to use them. If you map your symptoms to SNOMED CT codes, and you have a patient comes in who speaks a different language, can you imagine how hard it is for somebody with a different language to communicate what they need to communicate to their doctor? If you map to SNOMED CT, there is no reason you can't provide those symptoms in the language of the patient, gather the full set of symptoms, and then show those symptoms to the provider in their language. So integrating the appropriate data standards into those tools is absolutely critical to help patients across the board. So within the tool, once they've selected their symptoms, they get a personalized tracker. Just with the symptoms that they've selected, it reflects their state of health. And on a weekly basis, they go in and they select 0 through 10, so they capture the severity level. So by doing this, when they walk into their doctor's appointment and they sit down in that chair and the doctor says, so what's going on? You get a full set of data. You see how it's trended and changed with time. And now you can spend the appointment talking about the information and why, and not just trying to capture an incomplete set. The second set of data that we capture is medications. So Katie had 6 specialists, 4 of whom prescribed her prescriptions. And so we were the only ones who had data in one place that showed that full set of medications. When we were into her illness, there was one particular medication. Katie mentioned the importance of giving her treatment that actually increased her function and quality of life. So there was one medication that she was given that helped her pain. It was supposed to help her pain. We ramped up 6 weeks worth to trial on that particular drug. And at the end of the time, she had reduced from a 7 out of 10 to a 5 out of 10. some improvement. However, she lost the ability to focus. And Katie talked about the importance of having a therapist in place and having psychological care. So that therapist had taught her coping skills to deal with the pain when it got that level, and she could focus through it, so she was actually still functional despite the pain level. But when she got down to that level 5, the medication side effect made it impossible for her to focus and concentrate. So she had a choice. She could live with the pain level 7 and function, or she could go down to a pain level 5 and lose her functionality. And so she chose to come off that medication. So in the next 2 years, we saw 4 other doctors, and they all say, we know exactly what she needs to help with that pain. But because we had that data, not only how long we tried it and the dose that we went to, but also the symptom response and why we stopped it and the impact it had on her life, the first 3 guys said, let's not do that. And the 4th one said, you know, things have changed enough based on the data, it's worth another try. So we did try it again, but we tried it with the right set of information. Right? So patients having that data in their hands and knowing is really valuable to be able to provide it to every single doctor. Right? And it also, of course, brings up a view of their current medications. I want to mention data standards mapped to RX norm. Right? You want to make sure that the information on the screen matches what's on the prescription bottle. Again, it eases integration. So once the medications are in the toolkit, you get reminders. It's in the schedule. They don't have to remember to take the medications. But we mentioned before, there's good reason for not taking medications sometimes, right? So Katie went from the advanced academic program into a special needs self-contained classroom at school. When she had an exam in that self-contained classroom, there was a medication I did not give to her that day. And the reason I didn't give it to her is because if I gave it to her, I knew there was a good chance she'd fail the exam because of the side effects. And holistically, we looked at her as a whole and said, it's not worth taking that medication today. It is better for her to skip it. So the key issue was not just compliance. The key issue was we could explain to the provider why they couldn't take the data, and so they could then change the treatment plan to be something she could follow. I'm going to hurry just a little bit because I'm seeing my time here. So within the application as well, we talked about developing it in a way that could be used on a day-to-day basis. It has a scheduling component, so it helps patients organize what they have coming up. They get reminders to remember things. I want to mention the life note very briefly. The life note, when you're a chronic patient, you're thinking of things all the time that might be important for the provider. There was a wonderful presentation, actually, the lady sitting here, and Jan Oldenburg on Tuesday, that talked about the importance of patient stories and the importance of journaling. So we have a journal that's actually built in here, and when a patient does a journal entry, they can tag it as a provider's note. So when they walk into their doctor's office a month later, they will remember that important piece of information. They can also use the journal to take a photograph of a swollen joint or a rash or a plate of food if they've got questions about things, so that it's easy to communicate with that provider. And then we also talked about the sharing of the data. Sharing is critical. So we've developed this framework with input from providers and patients, of course. Everybody wants to see things differently. That's the bottom line. Okay? They want to see it in their own way, and they want to make sense of things in their own way. So we built a framework within the tool. There are ultimately 4 rows of data we collect. We collect individual symptom severity levels. The second bar down shows the total symptom load of the patient, so you can see overall how they're improving with time. The third row down is how are you feeling today, which is often an early indicator of depression, because if they've got a red, how are you feeling today, but their symptoms are doing really well, that's a red flag that there may be something else occurring. And then at the bottom you can see the medications and see whether they're taking them or not. So using this framework, patients can look at it to say, well, you know, my mood is getting better right now. You know, the symptoms are getting worse. If you've got that gut feeling, you have your own data to validate it. But also the providers could use the data also to say, well, what did happen when I gave them that medication? Did it improve things or not? All of those rows can be collapsed down because sometimes this is just too much to process. You can make it as simple, or you can drill down into details to get to a lower level of information. We also have a dashboard built in for those who aren't as graphical and want to see the numbers. And again, within this dashboard, you can actually drill back down and back to specific days and see what was going on, or specific symptoms, and see how it trended. I've already talked about the infrastructure, the importance of data standards. This is personal data. Even though it isn't HIPAA required because it's patient-owned device and data, it's very important to enable privacy. So we have built in an encrypted backend. There's a secure login. And again, I want to emphasize, everything I've shown you today could be done on a piece of paper. It can be built into a home nursing system. So when the nurse actually goes out and speaks with patients, they can gather this information and capture it so that the next time they go back, they can actually look back and see the difference. So I talked earlier about a cultural shift in how we view patients. We're not going to get a cultural shift without evidence. We don't put systems into providers' hands without evidence that they work. And we need to start thinking the same thing about patient tools. So MITRE, we're doing research. We had a collaboration with the Carnegie Mellon to do a provider survey to make sure and understand how they would use this data and if it would help them for diagnostics or treatment evaluation. And the survey response came back very positively, saying we would love to have longitudinal severity symptom data and longitudinal medication compliance data, but there is no way of getting it. And they also told us how they would like to view it if possible. We also did a clinical study with the University of Virginia, which is being published in April in the International Journal of Medical Informatics. So this was with 33 multiple sclerosis patients, and it was before we had the full tool, so we actually gathered data from them through a web interface and also wearable devices. And that study did come back, and the one thing that was really, there were two issues in particular that were really critical that came out of that study. The first one is you can rely on the data that you collect at home as much as the data you collect in the clinical setting. So we were able to prove that the symptom severity levels that they reported was at the same reliability level than if they were sitting in the chair in front of the provider. And the other thing that we were able to demonstrate is over 50% of those patients had an improved understanding of their disease state. So really big potential. We took the feedback from those patients, which included, will you please make this mobile, and helped integrate that feedback in order to build the toolkit. And actually, so the next, we're now preparing, now that we have the toolkit built, we're actually preparing and we've just completed phase 1 of a large-scale clinical study with rural patients in Montana. So I talked about this being a cultural change. Just having the technology is not enough. You have to have the evidence. And the evidence can't just show that you improve health outcomes, but you have to start looking at the impact on clinical workflow. You have to understand how clinicians will be able to use this data in the clinical setting. And so the study that we're doing in Montana, we're going to be sending the patient toolkit home with multiple patients. We're going to be measuring their usability, their health outcomes across the board. We're also going to be looking to see at the number of ER trips. So does increased self-awareness of disease state result in picking up that phone earlier and reduce the number of readmissions and ERs to the hospital? And the reason this is important is because if it does, the hospital costs reduce. Right? In order to really get this cultural shift to go forward, we need providers to have the evidence to show how this will improve their system and their ability to provide care for patients. So the study we're doing will be gathering information around that and looking at how it integrates into the workflow. And we're also, there's one last piece of this, because again, to get a cultural change and really look at the enterprise view from patient all the way through, you have to look at payment. And you have to look at policy, and you can't ignore it. So we've just done a deep dive. 2 years ago, we looked at the policies that would support these sort of tools and this sort of patient-generated data. Fee-for-service had nothing. There were no relative value units that providers could use to charge for the time looking at this sort of data. Clinical quality measures have patient transactional satisfaction numbers in them, but you can have a really good clinical quality measure, but you could be in so much pain that you can't get out of bed. So on the old system, it didn't work. But now with the macro legislation and the new rollout of these payment plans with MIPS and with APMs, now there's a way to get paid for the use of this type of patient-generated data. And this is opening the door, which is why now is such a good time for us to be moving forward in this space. So the study that we're doing, we're also going to be able to capture data to show and demonstrate how this sort of information may be used to support these new payment models in order to actually make this sustainable. So in summary, we talk a lot about patient engagement and patient empowerment. They're common terms in the healthcare language today. We put the patient in the center, and this is kind of cool, right? You focus on the patient and you focus on the caregiver, and we talk a lot about how to communicate them in a way that they can understand and how can we do things for them. What we've been talking about today, this is okay, but it's not enough, and we're ready to take that next step. We're ready to say patients and caregivers are experts, and they're valuable and equal partners with the rest of their care team. So they shouldn't be in the middle. They should be seen as recognized experts along with the rest of their care team. There's 117 million patients in this country today like Kate. There's 54 million caregivers like my husband Frank and I looking after those patients. We were one of the lucky ones. We had the background, and we had the support to be able to engage as experts and help Kate turn Kate's care around. If we hadn't been that lucky, Kate may not be here with me today. There are millions of patients who are at the same brink that we were on 3 years into her illness, and they deserve the same opportunity and the same support and ability to engage as we had. And together, we can make that happen. Thank you. So I think we do have a couple of minutes for questions. If people would like to use the aisle speakers, that would be great.
Well, I think clearly a lot of us, nurses, doctors, people who maybe have chronic conditions, certainly appreciate your willingness to share your stories and take it that next level. In general, how have the providers been receptive? I know you had a care team that you worked with, and those guys clearly were very receptive to the information you were bringing them. What about your provider who maybe didn't go through that with you?
Yeah, thank you for that question. So in general, we've had very positive response from providers. They want the data. The fear is the impact and how do I do it on top of everything else. So one of the reasons that we emphasize the importance of being able to integrate the data in is that really to get this sustainable, we need to be able to demonstrate the model. We need the electronic health record system developers to start integrating this patient-generated health data in. And we can do it. It maps to the same standards. It's not that hard, but we have to value the data in order to be able to do it. The other thing, the reason that we're doing this rural study clinic with the providers is to really understand what the implication is on that clinical workflow. And the one thing I would just appeal to everybody, we do research on all sorts of things. We do not do enough research in this space. We have evidence of all sorts of pockets of benefits of patient engagement, but there's a lot more research. And if we do the research and we have the numbers, we can absolutely address the concerns and issues of the clinicians. But they want it. They're just not quite sure how to get it right now. Thank you.
My name's Morgan Knackle, and I just want to say I really enjoyed hearing your story. I am a patient as well. I have a chronic illness that took 4 years to diagnose, and though my stack of records was not as large as yours, it was very big. How did you go about getting your records from those paper formats to the digital standards that can be ingested within an EHR?
So I can answer that one. I mentioned I did satellites in the day, so midnight to 2 a.m. was my window, and I would hand type. Because when Katie first got sick, we had only one provider who had a patient portal, and the information that I could download was on PDF. So what I ended up doing is I went to every single office, I hand carried back photocopied versions of our support, and then I hand typed in. And it was not the way to do it. So other ideas for tools, please make that easy for us. And don't just make it PDF, make it something I can import into a spreadsheet. That's my concern, that we were lucky enough to be able to do that. There's an awful lot of people who want to do it and aren't able to do it. But thank you for the question.
Thanks.
Any other questions today? So one last reminder, we'd really appreciate it if you could go in and do the survey on the app. We would very much appreciate the feedback. Thank you again very much.
Thank you.